Yes, we can, doctor.
Okay. So today's lecture will be on blood transfusion. Actually, it's mainly on blood transfusion, the blood products, and its complications. So looking at the definition, so basically it's a procedure in which a patient receives blood products through intravenous line, and it's or the also known as introduction of blood components into the venous circulation. So the blood groups, there are actually about 20 genetically determined blood groups, but the one that we commonly use is the ABO and the rhesus. So ABO basically determines the type of blood group you're getting. Rhesus will determine whether you're either positive or negative. So prior to blood transfusion, this is the one process that we do. It's called blood group and cross match, meaning we have to determine the blood's group and then we will have to cross match whether the blood is actually suitable for the patient that we're going to transfuse. So each of patient will have one of the following blood types: A, B, AB, or O. So as we all know, O's are known as universal donors. So they can donate to any of the other blood groups. As for AB, they can only receive AB bloods. Plus, each person blood is either, as I mentioned just now, Rh positive or negative. That has to be determined as well prior to transfusion. So usually, one of the commonest types of blood when we don't have when we don't know what is the patient's when we rapidly need to transfuse, but we don't know what's the patient's blood group is, we will keep a O blood, either O positive or O negative. We call it safe O in each of our emergency department. So when patient comes in with rapid bleeding, we do not have time to cross match yet. So we usually use the safe O and transfuse first while waiting for the patient's cross match to come. If we have time, then we don't use the safe O. So each hospital is actually equipped with blood products. Usually it's a O blood product. We call it safe O. It's I think we keep about 2 or 3 points blood just in case patient comes in rapidly bleeding. We cannot transfuse them, cannot cross match on time. We use the safe O for that. Once we have determined the blood group, then we will transfuse according to the blood group and rhesus as well. So this ABO blood group types, it actually shows you which antigen they have and which antibodies they have. So as you see for the type O, they have both anti-A and anti-B antibodies, but they don't have either A or B antigens. So this one is just summarizing back the picture here. This is not very important. So the next thing that we determine is the RH or rhesus. So rhesus as they have mentioned, if it's present, they are rhesus positive. If it's not present, then they're negative. So it applies for all these groups. Every group has a rhesus. Either your B, your A, B, or O, you have either rhesus positive or negative. So if you follow the rhesus and the blood group, so when we group them, there's actually 8 different blood groups that you can get. So as it shows here, it's either your A positive negative, B positive negative, AB positive negative, or O positive negative. Anyone knows which one is the most rarest blood group here? Anyone knows?
Is it O negative, doctor?
Is it
A
AB
neg.
negative?
No, not AB negative as well.
Own negative, is it?
Yes, yes, O negative. So if you're O negative, usually you'll be contacted by if you're already determined to be O negative. There's a database in the country that lists you down. You'll be always on in which they will have a contact number if there's a person who needs O negative blood, because it's very difficult to source the O negative blood. So when they rapidly need O negative blood, either the patient needs it for surgery or for something, they will contact the fellow. So the O negative is a very rare blood, rare, very rare blood group type. So each country they'll have a database to keep all the O negative uh, persons, especially you have donated blood before, so they'll keep the blood bank will keep your numbers. So in case they need to contact, they will contact you for transfusion. So the bloods in used in transfusion must be compatible with the patient's blood type. So later we will look on what happens if it's not compatible. So as I mentioned just now, O blood is called the universal donor, and AB are universal recipients, meaning they can actually receive A blood, they can receive B blood, they can also receive O blood. So here they've mentioned here, patients with R positive rhesus can get positive or negative rhesus, but those with negative should only get negative rhesus. So basically, this is it's following back the same definition. So if you look at the second line, transfusions usually involves the use of two sources of blood, one's own or someone else's blood. So if you're taking your own blood for your own use, it's called an autologous transfusion. Or if you're transfusing someone else's blood, it's called allogenic transfusion. So most of our transfusion in hospital setting is allogenic. Anyone has heard about autologous transfusion? Okay, quite right. Autologous transfusion is not commonly done, but there are some patients who, when if they're going for a major surgery and they have time, let's say they have like 3 or 4 months ahead of time, some will actually prefer to use their own blood. This is mainly in the Western countries where they have good blood bank support. So they actually go blood bank. They actually donate their own to be kept. So when they go for surgery, let's say they've been donating every week or every 2 weeks once up until the surgical date, they probably will have enough of their own blood for transfusion. So it saves them from getting transfused with another person's blood. So they if they don't want to be transfused with another person's blood. So that is one of the options. I'm not sure whether the private hospitals here have that facility, but in Western countries they do this a lot, autologous transfusion. So you do not receive another foreign protein, meaning another person's blood. Plus your body itself, if you donate 2 weeks once, your body actually replenishes. Same like how you give blood for donation. So if you're donating to keep your own blood, your body will replenish. Then you go again, donate again. So they do it, and they will save up their own blood if they're going for a major surgery. So next we will look at the blood product components, which is the usage of whole blood, red blood cells, white blood cells, plasma, and clotting factors, plus platelet. So blood usually it's collected from donors who have been screened. Most of the time, those who want to donate blood, any of you are blood donors here? Have you ever donated blood before?
Yes.
Okay, so you all have sure have been through this process. They will screen your blood for hepatitis B, hepatitis C, HIV, and also syphilis. So these are the commonly known infective screeners that they screen for. Then after that, they will determine your rhesus as well. So usually they will give you a card saying that your what blood group and whether it's rhesus positive or negative. So that will be actually checked as well when you're donating the blood. Then depending on whether they need your blood, uh, if they want to use it as a whole blood or a packed cell, or they want to break it down into subcomponents. So we'll look at the subcomponents in a while. So then they will decide that at that time, and then they will move on to using the blood components. So one of the main components of blood transfusion is whole blood. So this blood is unseparated. It contains all of the blood components. So whole blood, if you look at that, it's 450 mils of donor blood. They have about 50 mils of anticoagulant preservative solution. So that carries about 12 grams of per milliliter of hemoglobin, and the hematocrit is about 35 to 45%. So this is usually not sterilized. It's capable of transmitting agents in cells or plasma. So the advantage of whole blood opaque cell is that it has coagulation factors, and its factor reach is more metabolically active than stored blood. So storage, usually bloods are stored between Celsius 2 plus to 6 plus degrees. So they keep it in a blood bank refrigerator. So transfusion should be started within 30 minutes of removal. So once you've taken out the blood product from the refrigerator, so you have to give it within the 30 minutes. And then has to be completed within 4 hours. Usually the blood transfusion usually takes about 4 hours. So when do we use whole blood? It's usually used when there is red cell replacement needed in blood loss, especially hypovolemia. So red whole blood has a lot of volume, so it's good for to replace blood volume. So in patients with cardiac failure and chronic anemia, it's contraindicated. So we do not want to give a lot of volume in these patients. We will probably want to use Paxil rather than whole blood. So Paxil, like whole blood, is another component. So this is actually spun down, and they get more concentrated version of the whole blood. So it's about 330 mils compared to a whole blood, which is 450 mils. So the hemocritic component is more, it's more per cut, so it's about 50 to 70%. So they are also stored at the same centigrade, 2 to 6 degrees. Carries the same infection risk as well. It's ideal in anemic patients because you don't want to give a lot of volume. You want to give less volume, but more hemoglobin. So we use packed red cells. So the next component that we look at is fresh frozen plasma. So this is not to replace your hemoglobin. This is to replace your coagulation factors. So anyone knows the type of coagulation factors? Have you all heard about the coagulation factors? Berapa kita ada? Anyone? Do you all know about the coagulation factors?
12 is it, doctor?
Yes, correct. It's 12. So this goes back to the if you can Google your coagulation cascade, you can see all the coagulation factors and where they work upon. So fresh frozen plasma is actually your blood broken down. They only retrieve the plasma out of it. So this is actually rich in coagulation factors. So when patient have coagulopathy, meaning so when bleeding happens, first patient actually loses hemoglobin, meaning they lose blood from the spot. So after which your body will try to stop the bleeding by using the coagulation factors to form a clot. But if the bleeding is continuously ongoing, the coagulation factors cannot keep up, then patient will actually lose coagulation factors as well. So body cannot keep up with the demands, then you have to actually give these patients fresh frozen plasma to replace their coagulation factors. So this is different. If you look at it, it's stored at -40 to -50. And it has a 2-year shelf life. So if you take out the blood today, you can still use it 2 years from now. As opposed to just now when we look at whole blood, it's usually used. So you usually use it in those with liver disease, warfarin overdose. So in warfarin overdose patients, we actually give warfarin to prolong their coagulation. So when they have some bleeding episodes, we actually give them coagulation factors. So those who are actually getting a large volume of transfusion, let's say a patient comes with trauma or an upper GI bleed or lower GI bleed, they're losing a large volume of blood. We give whole blood, we give Paxil, plus we give them FFP as well, fresh frozen plasma. So one of the precautions we look at is that it can actually cause severe allergic reactions, even ending up in anaphylactic reactions, but it usually does not occur. Next blood component that we look at is platelets. So platelets, so they will actually, when they spun your blood, they will actually retrieve the platelets separately. So this will be stored in a special agitator, and platelets shelf life is only 5 days. So once it's required, it's spun and removed from the whole blood, then you have to use it within the 5 days. So it's usually given with patients with thrombocytopenia. So thrombocytopenia meaning patient has low platelets. It's either because of platelet dysfunction or they are having bleeding. So commonly, it's those who are having bone marrow failure, platelet dysfunction is used. Those with ITP, TTP, and DCIS, we do not use platelets. In these patients, they have enough platelet supply, but the platelets are dysfunctional, so we do not give them platelets. And those with hypersplenism, your spleen, this patient's spleen is actually enlarged. So one of the function of the spleen is to clear off old platelets. So when they have hypersplenism, the spleen itself actually clears off the plates. If you give them more platelets, the spleen actually still clear. So it's not indicated in patients those with hypersplenism. So about 4 to 6 units of platelet will increase the platelet count by 20 to 40. So one easy way to remember, I usually remember this is 1 unit of platelet increases your platelet count by 10. So the complication is the same. They can get allergic reaction and febrile reactions as well. So platelets usually it's stored. Then we will give it. This is usually stored in a room in a special agitator in room temperature. So the last one of the last components that we look at is cryoprecipitate. This is also another. It's actually spun further from the fresh frozen plasma. It's rich in factor, specifically in factor 8 and fibrinogen. So if you ask me what do they use this for? So factor 8, they use it for, if you go back to your old lecture, those with factor 8 deficiency, they can use this factor specifically, or those with fibrinogens, those with fibrinogen deficiency, they use this. So one of the commonest disease here is given here, von Willebrand's disease or factor 8 deficiency, which is hemophilia A. So this is more specific. So let's say you've already diagnosed this patient with hemophilia A, and they come in with bleeding episodes. You can actually give them cryoprecipitate directly rather than giving them fresh frozen plasma. So same 2-year shelf life. The storage degrees is almost the same as the one just now. It's about -30. So this, once you have removed it, you have to give it within 6 hours. So if it's used correctly, like it's mentioned, blood transfusion can be life-saving, as we all know. So decision whether to transfuse blood or blood products should be always based on a careful assessment by a clinician. So these are the indications for a blood transfusion. So acute blood loss or due to trauma, we would want to transfuse the patient bloods. So major operative procedures, we will want to transfuse bloods, especially when there's interoperative bleeding. Then in chronic anemia patients, let's say conditions like thalassemia, they will require on and off blood transfusion, probably 2 weekly or even monthly once to keep up with the hemoglobin supply. Other less indicated patients with severe burns, if they have bleeding episodes, you can actually transfuse them, and those with blood dyschariosis. So purpose of transfusion is to restore blood volume. Then next thing is to replace the clotting factors. Why would you want to restore the blood volume? You want to improve the patient's oxygen carrying capacity. Then also to prevent complications. So if you ask me, okay, so let's say the patient's hemoglobin from 12 drops to 8. Any complications that can come from that? What do you all think can happen? Why do you want to replace the blood volume? Anyone?
To prevent shock, hypovolemic shock.
Yeah, to prevent hypovolemic shock. So patient can go into hypovolemic shock. One. So especially with when we see, especially younger age group and older age group, their reserves are not very good. So let's say pediatric group of patients and geriatric group of patients, they come in, let's say they have to go for a surgery or they come in emergency, they lose volume, they go into shock very fast. So when they go into shock, as I've mentioned the shock lecture before, after a while your body cannot goes into a irreversible shock. You cannot reverse the shock anymore. So once it goes into irreversible shock, then most likely you will end up in multi-organ damage, and then we cannot reverse it anymore. So until a certain level, they can compensate, but after it goes down, then it causes complications. Older patients, if they lose a lot of hemoglobin level, their oxygen carrying capacity goes down, so they can end up with stroke, they can end up with myocardial infarction. So that actually complicates things. So we do not want them to end up in that. So that's why we will transfuse them early, especially when they start losing volume. Same applies for pediatric patients as well. So complications of blood transfusion, you can actually divide it into immunological complications and non-immunological complications. So immunological complications, if you ask me what does it mean by immunological, so it arises from your body's own reaction due to the proteins, the foreign proteins present. When you receive a patient's blood, even though the results is matches, the blood group matches, it still has foreign proteins of another person, meaning another human. So it does not fully, it's not fully compatible uh, to the person receiving it. So in these cases, there they will develop immunological reactions. So if you look at non-immunological reactions, this is due to volume, probably due to infection if the blood is not screened, due to other complications as mentioned there. So the first one that we usually get is febrile non-hemolytic transfusion reaction. So this is commonly seen in clinical practice. So once we give blood, after a while we notice that once the patient has been starting to get blood, patient has chills and rigor, and then we check patient has fever. So this is because of the cytokines which is present. So there's a foreign protein present in the patient's blood, another patient's blood. When you're giving it to another person, so your body reacts to it, and from the reaction you actually get a fever. Usually this is self-limiting, doesn't cause much issues. Most of the time we just give them paracetamol and we'll manage them accordingly. Another reaction that we get is allergic reactions. So their skin turns red, become they have itching episodes. This is similar like eating something that can cause you allergy. So like let's say you take foreign proteins like seafood. Some of you get this, right? It's a common thing that we see. Unless it's very severe. So if it's severe, then we have to actually stop the transfusion and manage the patient accordingly. So mild treatment is usually steroids and antihistamine. The next one is the severe form of transfusion reaction. So it's called acute hemolytic reaction. This usually happens when the wrong blood is given to the wrong patient. So this is, I don't think you all will get into this, but for us in our practice, we see this often. So when we take a patient's blood, we label the name wrongly, or when we are going to give the blood, we give it to the wrong person. This is where the acute hemolytic reaction occurs. So if you give a wrong blood to a wrong patient, they will get acute hemolytic reaction. It causes intravascular destruction. They can end up with even DIVC. So this is usually due to clerical error. So, so usually what happens is when a patient comes in, we will withdraw the blood. There's a form there for blood transfusion. So we will check with the patient whether the name is correct, the IC is correct. Then we will take the blood. Then we will label the sample accordingly and we will send it. So if it's this job is done by a few different person, let's say one person is labeling it, the other person is taking the blood, that's where problems occur. Or once you have already sent cross-matched, once the blood come, so before transfusion, you never check with the patient. So is this blood meant for that patient or not? Or the name is same. Let's say you check both the patient's name is Muhammad Ali, then you give to the wrong patient the wrong blood. This is where the acute hemolytic reaction happens. Dental practice, do you all have to check for group cross match? Do you all have to transfuse patient? I'm not very sure about this. Maybe hospital setting, yes. Anyone knows about this?
It's when there's a mismatch in the blood group.
Yeah. Do you all have to transfuse? I mean, do you all have to withdraw blood? Have you all heard about it from your seniors before? I'm not sure about dental practice.
I think no.
No. Maybe in OT setting, yes, especially OMF if they have cases. But I don't know whether you all are. So this one happens. We commonly see this with our housemen. So because one of the persons taking blood will be housemen, so they'll be taking blood for a lot of patients, in the ward. So one of the bloods that they have to be more particular is when it's sent for cross match. So if it's labeled wrongly, it will be cross matched wrongly, and the patient will get the wrong blood. So it's actually a multi-step process. So you have to go through as a team, meaning the houseman checks it, the medical officer checks it, the nurses check it, so that to prevent error, but it still happens. Okay. So wrong blood, patient gets the wrong blood, they'll get a severe hemolytic reaction. So one of the features that we see, they can develop fever, so they can go into hypotension, tachypnea, dyspnea. They even get flushing and anxiety. So treatment is usually just supportive. Give them fluids, diuresis, and if they're still bleeding, then give them transfusion support. So another complication that we commonly see is called transfusion-related acute lung injury. So this is same. It's because of the patient's the donor's antibody. It affects patient's human leukocyte antigen or leukocyte specific antigen. So this will cause neutrophils to release toxin products, which eventually results in ARDS. So ARDS stands for acute respiratory distress syndrome. So commonly, after you give like a large volume of transfusion, patient complains of dyspnea, hypotension. They are they have difficulty to breathe. When you do an X-ray, it shows a whiteout infiltrates. So they have lung injury because of the transfusion. This is not very common, hardly seen in practice, but we do get, especially with large volume transfusion, we do get Raleigh patients. So infections. So one of the other common things that used to happen with blood transfusion is infections. So now we actually routinely screen for it. So we have actually lessened the amount of infections from blood-related products. But back in the 80s, when HIV was first discovered, it wasn't routinely screened for. So a lot of patients who received blood products back in the 70s, 80s. So when they look back, why did they actually develop HIV is because of that. So HIV patients donating their bloods, it's not screened for routinely. So a lot of people ended up with HIV back then, those who have received blood. So now commonly we will screen for blood products for everything. So we check for hepatitis B, Hep C, malaria, syphilis. So this is all to prevent infections related to blood transfusion. So next one we look at transfusion associated cardiac overload. So this is a non-immunological reaction. So what happens is you give patient volume, they cannot manage the volume. So this, especially in patients with those with end-stage renal failure or those with cardiac failures, so they cannot take a lot of volume, then they're complicated with TACO. So they get dyspnea, hypertension. So they get fluid volume overload basically. So this one we will have to make sure that these patients are, if we know that they have end-stage renal failure, probably instead of using whole blood, probably want to use Paxil, or patients with end-stage renal failure, we will transfuse them during dialysis, meaning extra fluid is removed from their body. So other complications that we get is transfusion-related purpura, graft versus host disease, immunosuppression, iron overload. These all are rarely seen. So delayed hemolytic reaction so previous antigen to transfusion of pregnancy, this can result in hemolysis. This happens 2 to 10 days after. Commonly flu-like symptoms or recurrent anemia and jaundice. This is all this is rare, and this can be managed symptomatically. the one that I mentioned, graft-versus-host disease. So the T cells attack the host tissue from the donor. So this is actually rare, but it's known to be fatal. So not commonly seen as well. So the features of this is pancytopenia, rash, liver dysfunction. This one is difficult to treat. So what is the definition of massive blood transfusion? So massive blood transfusion is actually replacing a patient's whole blood volume within 24 hours, or a single transfusion more than 2.5 liters. So imagine the patient comes in actively bleeding, you replace the patient's whole blood volume. So let's say a male's whole blood volume is 6 liters, you replace the whole 6 liters. So this is defined as massive blood transfusion. Or a single transfusion, you give patient more than 2.5 liters. So complications of this, patient can get coagulopathy, hyperkalemia, hypokalemia, citrate toxicity, hypothermia, infections, and the ARDS I have mentioned just now, TRALI. And they can also get transfusion reactions. So why do they get these issues? So when we replace the patient's blood volume, let's say we are giving 1 liter of blood, preferably we want to transfuse fresh frozen plasma together, so that they don't end up with coagulopathy. So when you lose blood, the plasma factors has to be replaced as well. And how do they get hyperkalemia? So stored blood products have a lot of potassium in it, so that can cause hyperkalemia. So another thing that they get is citrate toxicity. So citrate is one of the products. It's a solution to actually keep the blood, to help store the blood. So citrate, it causes two things. So one is citrate toxicity. Second thing is citrate reduces calcium volumes in the serum, so you can get hypocalcemia as well. Next complication that we see is hypothermia. So bloods are usually, they have to be warmed before giving. So giving cold blood can actually cause hypothermia in patients. Then the others we have mentioned just now: infections, incompatibility, and ARDS is from the TRALI, the transfusion-related acute lung injury. So I'll go back to the first slide. Any questions from the first slide? Anything that you're all not clear of? This lecture is very important for MCQ questions. Okay, a lot of things from MCQ is asked from this lecture. Okay, multiple choice questions. Yeah, MCQ. So yeah, multiple
MCQ
choice
for
questions.
the upcoming
Upcoming
minutes
also have to. Upcoming definitely will come out. This lecture will come out, and even for your other MCQs as well. So try to remember the degrees it's stored, the product, what degrees, how long is their shelf life. Okay, and also try to remember the complications of blood transfusion as well.
Doctor,
Yes.
how about other topics?
So all the topics that I've it's has been covered so far will come up for the MCQ. Yes. I cannot hear you guys clearly.
Basically, doctor, our 4-minute test is until this one, lah, right?
Yep. Until this one.
Okay,
This
okay.
is important, huh? So I have
Okay,
to read. Have to read this. I'm this one. usually won't come out for short answer questions. Usually won't come out for, but MCQ I can ask a lot of MCQs from this.
For SAQ, you give 2, is it? I mean, how would you give us the questions? Like how many MCQ, how many SAQ?
I cannot hear clearly. Come again.
Okay. For our upcoming mini test, right, doctor?
Yep.
How much? I mean, how much MCQ and how much SQ?
Okay, so the mini test questions, and there's 2 short answer questions, short essay questions. So the MCQ questions, each question carries 1 mark, which is 20 marks total. As for the short answer question, 1 question carries 10 marks. So that is about 20 marks also. Next week, right? Next Tuesday, right?
Yes, doctor.
Okay.
Got anything else?
Nothing much else, but this lecture is definitely coming out. So I'll suggest to read about this.
Doctor,
Yep.
can you tell us about what topic came up for SAQ?
Unfortunately, I haven't prepared the SAQ questions yet. MCQs are prepared already. SAQ no. But I'll suggest to read all of the lectures, the ones that I've given before.
Okay, thank you, Doctor.
This one not coming. This one won't come out for your SAQ. This lecture. This is more MCQ.
Okay, doctor. I think that's all from us.
Okay.
Before that, before we end the class, we take picture for
Yeah,
attendance.
sure. Can.
Satish Prashana, your camera. Okay.
Prashana, join me.
1, 2, 3. Okay.
Thank you, doctor.
Okay. Good luck for next week's mini
Thank you,
test.
Doctor.
And happy
Okay,
New Year,
doctor.
everyone.
Happy New Year, doctor.